Hello, everybody. Hello, madam. Hello, you're on mute. You can unmute yourself.
Hi, ma'am.
Yeah, nice to see you. Good, good. So, all set.
Yes,
आज
ma'am.
जल्दी आ गए.
Yes, ma'am.
Yes. एक मिनट. हॅलो अश्विनी मॅडम.
हाय मॅडम. काढो घेतो. या हॅलो.
हॅलो.
आले सगळे कोण?
पार्टिसिपंट सध्या 12 आहेत. वायबी सर जॉईन होत आहेत.
ओके.
सर आलेले आहेत. मी मनीषा मॅडम आणि आपल्या अविनाश सरांना फोन करते.
चालेल. त्याची फक्त मी नावं घेते.
चालेल. Hello, sir.
Good evening, madam. Good evening.
गुड इव्हनिंग सर.
I am extremely sorry. It is little too late at night in Sydney, so I'll be showing my face just for a couple of minutes.
Oh, is it?
Oh my God, you are in Sydney. Good evening.
Yeah, good evening, sir. Good evening.
Good evening, sir.
Good evening. Hi, how are you? Good to see you all. Great. Great.
Since you are with your son.
Mobile.
Yeah, that's right.
Really commendable, sir. It's really very late in Sydney.
Nice. So at 10:30 over here, it becomes at 8 o'clock. It becomes dead over here, you know, and the concept of street light is not there. So everything is absolutely pitch black and dark, you know, and
Once
cold
again.
also.
So once again, hats off to your commitment.
मैं तो सो गया था, शिल्पा ने उठाया.
क्या बात कर?
Good, good. I'm glad to see you all. I'm so happy. Wonderful.
So glad to see you, sir.
Yeah, great. Thank you, madam. Thanks a lot.
हम्म.
Nice to see you all actually. यहाँ तो मुझे तो ये समझता नहीं कि आज तारीख कौन सी है, और वेकेशन संडे मंडे भी समझता नहीं है ना.
सर जल्दी आ जाओ, फिजिकल मीटिंग करनी है, सबको चाहिए.
Yes, yes. एक जब तक एक RTM कर लीजिए, then as soon as I come,
अच्छा.
I have 2-3 things in my mind, तो वो कर लेंगे फिर हम लोग.
ठीक है सर.
Yes.
ओके सर. अविनाश सर जॉइन होता है. ही इज ट्रॅव्हलिंग. ही मोबाईल. आणि मग
साढ़े सर नमस्कार.
Namaste, namaste.
कैसे हैं सर? All good?
I'm fine. It's good.
मैं मेरा ब्लेजर ढूंढ रहा था, लेकिन it was ब्लेजर. Good evening. Thank you, madam.
I'm reaching home in 30 minutes. हाँ? ये गाड़ी चले जाएंगे. आपके वहाँ कितने बजे सर?
यहाँ पर हुआ है 10:30, but it is too late at 10:30 over here. यहाँ 8 बजे से everything is dead over here.
रात का 10:30.
Yeah, रात का 10:30.
लेकिन आप उतना मेरा देख सकते हैं.
Good, ना? Good to see you all. अच्छा है.
तो आप प्लीज कम soon. जल्दी जल्दी आओ.
Yes, yes. अभी आके बहुत काम करना है ना मुझे तो भी.
yes.
Definitely.
शिल्पा वैसे भी छोड़ने वाली नहीं है.
हमने
शिल्पा है
लिस्ट
इसलिए सब
रखा है कि सर आएंगे तो सर इसको फोन करेंगे, इसको ये करेंगे, उसको वो करेंगे.
नहीं, अभी तो अभी टोटली डिवोटेड. एक बार वहां पर आ गया सब कर लूंगा.
कॉन्फ्रेंस का डेट नजदीक आ रहा है.
Yes. Lots of planning is going on and lots of work is being done. Good, I'm glad.
थैंक यू सर. मैं मनीषा मैडम को एक बार फोन करूँ.
Avinash, good evening.
Good evening, sir.
How are you? How is
Hello.
Satara? It is cool. Satara is cool.
No, sir, it is hot. I am just traveling.
Traveling? Oh, you are driving.
Going to emergency cesarean section, 15 kilometers from Satara.
Oh my God.
Oh. ऍक्च्युली भट सर जॉईन झालेले म्हणून मी अविनाश सरांना म्हटलं जॉईन व्हा. भट सर आर यू देअर?
हा सर आहेत की दिसतायत, मगाशी दिसले होते ना सर.
दिसल्या होतात ना. हा.
गुड, नाईस टू सी ऑल. पण अविनाश असा आहे की तिकडे साताराचे
एकदम छान.
15 मिनिट आहेत. साताराच्या 15 किलोमीटर इज इक्विव्हलंट टू
इमर्जन्सी सेक्शनला
प्रोबब्ली 100 किलोमीटर ऑफ मुंबई. यू नो, उधर 1.5 किलोमीटर निकालने को 2 घंटा जाता है.
हाँ सर, अभी तो वो बीच में क्या होता है, वो कनेक्शन टूट जाता है बीच में, वो रेंज का प्रॉब्लम है.
Yes, yes, yes. While you are
माउंटेन है ना,
traveling, the
बीच में
range goes
माउंटेन
up.
आता है, तो माउंटेन की वजह से थोड़ा सा प्रॉब्लम है.
Good, good.
ओके ओके.
Anyway, but it is good to see you all. I'm very happy with you. And you are doing, and Avinash is doing a good work. Let me tell you one thing.
सर
Oh,
मनीषा
thank you
मॅडम,
sir.
I
मनीषा
keep following the blogs. शाम को सब पढ़ता हूँ बैठ के, तो at least I read all those things. You know.
मनीषा मैडम ज्वाइन हो गए, हम लोग शुरू कर सकते हैं.
Yeah, you can start, madam. You only welcome everybody. आप ही कर लीजिए मेरा काम. I just had to show my face, and I just had to wish Avinash, Manisha madam, and Dr. Sale, my friend, सबको wish करना था. अनीता नेहटे को सबको wish करना था. बस बाकी काम आपको लोग करिए. I am most happy that you are there to do all the job while I am not around. Dr. Shilpa, please continue and wish everybody well on my behalf.
Yeah.
Thanks.
Yeah. Welcome.
Thank you,
everyone.
sir. Thank you.
Thank you so much, sir. We are blessed to have today Dr. Yogesh Bhatt sir, Manisha madam, Saleh sir, and Avinash sir, and all dignitaries with us. So we welcome you all to the ISA Borivali CME. Yeah, madam, you can take over. Ashwini madam.
Hello, good evening, everyone.
Yeah.
I would like to welcome all the committee members and executive members of Maharashtra State Chapter ISA on behalf of Borivali ISA branch. Let me just name our esteemed guests today. We have Dr. Manisha Karthikar, President, Maharashtra State Chapter ISA, Dr. Hanmant Sare, President-elect, MSc ISA, Dr. Anjali Bhure, Vice President, ISA National, Dr. Avinash Bhosle, Honorary Secretary, MSc ISA, Dr. Ashok Deshpande, National GC, Dr. Samir Sohani, Honorary Treasurer, MSc ISA, Dr. Anita Nehete, Vice President, MSc ISA, and Dr. Hemant Shinde, MISA News Editor. I once again would like to welcome and everybody, consider this as a personal, a welcome to everybody here. Can I now request Dr. Manisha Karthikar to just address all the delegates? Dr. Manisha madam.
Thank you, Ashwini madam, for such a nice introduction for our team of Maharashtra State Chapter ISA. Yes, I think I have become, Yogen sir, I have become a member of Borivali ISA. Because every month we are attending meeting of ISA Borivali, and next month or maybe now Shilpa, it is your responsibility to invite us every month till November, till I hand over the job of MSc ISA team to Sai sir.
100%.
Yeah. The topic today you have chosen is an excellent topic for Sai sir, and safe anesthesia practice is really important. And I would like to share my experience that I experienced about, like I heard about the word vigilance of anesthesia in JJ Hospital in the pediatric OT when I was second poster in anesthesia. Dr. Bharti Kulkarni madam was our HOD for that pediatric anesthesia OT. And Sare sir might also remember, because many of us are from JJ, done work in JJ during our postgraduate days. So madam used to say, be vigilant all the time in the OT, be vigilant. So being a second poster, just finished 6 months in anesthesia, I used to wonder what is the exact meaning of being vigilant. But what madam used to do, she made us realize the exact meaning of word vigilance. What she used to do, she used to, like those days when we were working in pediatric OTs with esophageal stethoscope in both ears and hand on the JR circuit continuously ventilating the babies, we used to get fully engrossed with hearing the heart sound with the esophageal stethoscope and then ventilating the babies with JR circuit. So what madam used to do, she used to just increase the nitrous oxide flows a little bit, just used to reduce the oxygen flows a little bit, and then she used to watch from other end of the OT that whether we are getting realized about the change in flows of oxygen and nitrous or not. And yes, if it would happen, madam kautukani sangaयच्या, yes, you are vigilant. And if we did not notice that change in the flow rates, then पाठीमागून एक बुक्का खाल्लेत बुक्के मी बऱ्याच जणांनी खाल्ले असतील पाठीमागून एक बुक्का असायचा you are not vigilant at all as an anesthesiologist. You should be sharp enough, though the monitors are there to help you, though you are ventilating the baby, but you should be vigilant to see around everything what is happening around you. So those who have done their post graduation from JJ Hospital might remember that madam had taught us the word meaning, exact meaning of word vigilance, and I'm really thankful to Bharti Avalegaonkar Kulkarni madam for such like we never use such good things from our teacher. बुक्के खाल्ले तरी काय झालं मॅडमनी शिकवलेलं कधीच आपण विसरत नाही. So with regards to Bharti Avalegaonkar Kulkarni madam, I'm really thankful to ISA Borivali for inviting me here. Thank you. Thank you.
Thank you, madam. Ashwini madam, to you.
Thank you, Manisha madam. It was nice to hear your experience, and I mean we would all really totally agree. If you have great, excellent teachers, we also become good clinicians and good students. I've just been told that Dr. Avinash Bhosle is traveling, but sir, is it possible for you to just address us for a few minutes?
Yes, thank you.
Is it possible, sir? Okay, then.
Yes. Can you hear me?
Yes, please take over, sir. We can hear you clearly.
Yeah. Good evening, everyone. There are different topics today, and ma'am, Manisha ma'am already talked about the vigilance and safety. So I would like to talk about the fitness. That is my favorite topic. So first, congratulations to Dr. Charu Shila for completing the Ironman competition. Look it as an inspirational or motivational speech for you. But don't think that everyone should do it. From this, even you start a walk for a few miles, if you are not doing anything, it is enough. If you are already doing some exercise, put one step ahead, push little more, just push little bit more. Don't do anything because someone is doing this or that. Doing exercise for fitness and for competition is at all different. Few sports exercise are for fitness, and some championships, events, or sports are played by fit person. I will give you example. Badminton or cricket is not for fitness, but played by a fit person only. I am running since last 11 years, ran all last 10 Mumbai Marathon and 9 Satara Hill Marathon, but I am not running regularly every day. I just start 3 months for full marathon and 1 month for half before the event. It is not possible to take out 3 to 4 hours for practice when you are a freelancer busy anesthesiologist. Today I also traveling 15 kilometers for a cesarean section surgery. It is not possible, but every day it is not possible. But every day I do something. In the morning, if I feel today I will go for cycling, then I do that. If I like to go gym, then I do go for gym, basketball, tennis, yoga, trekking, or even a relaxation day. Never compromise with my sleep or sleep for the exercise. It is most important. Listen to your body. पण असं पण नको की रोजच आपल्याला काय करू वाटत नाही म्हणून निवांत झोपायचं असं पण नाही. Build a strong mind setup. Set the body will follow. Look inside yourself. Find the real you that has the potential to do the wonders. Trust me, he or she can't motivate you, and nobody else can either do that. But there is someone who can help you. That person can solve your problem. That person can bring the confidence in yourself. That person can end your all difficulty, and that person is you only. And no one can stop you. The person you can stop you is the you only. Laugh, love, and live. I believe in these 3 L. Laughing is important to secrete endorphin. Love your body and love the nature, human being, everything around you. Live your life lively. Fit is not a destination. Make it way of life. That's all. Thank you for inviting me. Thank you for inviting me. Congratulations to all the ISA Borivali office bearers for their consistency in arranging events and the CMEs. Best wishes. Thank you. Long live ISA. Thank you. Thank you very much.
Thank you so much, sir, for sharing your fitness regime. And special thanks for giving us those cautionary tips, regarding going that extra mile. We try to, tend to at times, as you said, neglect or don't listen to your bodies, and we try to go the extra mile. Thank you so much for your cautionary tips. And it's exemplary because you are already going for a section and you're still managing to attend this and address us. Thanks a lot, sir.
Thank you. Thank you very much.
Ashwini madam, can you request Saleh sir?
Yes, can we move on to the next session now?
Meantime, Varsha madam, can we have the CV of Saleh sir on screen?
Yes, yes, ma'am.
Okay. In the meantime, as we get to see the CV on screen, let me just introduce Dr. Hanuman Sare to all of you today. Good evening and welcome, sir, once again.
Thank you so much.
Okay. I know there's a long list of achievements, sir, but still I would just like to go through that. Sir has done his MD and DA from
Nothing to be said, everybody knows it. Nothing to it. Thank you so much.
Okay. Okay, sir. But let me just touch a few things, as I said. Sir's special areas of interest are uro anesthesia, to set the standard for NABH accreditation, JCI, Green OT, and mainly it is to maintain quality standard and safety in anesthesia. So I think we've really got the right and the best person to address us today for this topic, that is safe anesthesia practice. Welcome, sir, and I would like to hand over the proceedings to you.
Thank you so much. Okay. Just a moment. Good evening to all. Shilpa, can you hear me?
Yeah, we can hear you and we can see your slides also, sir.
Can you see the screen? Everyone can see the screen?
Yes, sir. Yes, sir.
Okay. Dr. Ashwini, thanks for good words. And I'll just narrate why I selected this topic. Shilpa was calling me your topic. Honestly speaking, very few places I've worked in the small nursing homes rather than the private nursing homes. Since my beginning, I have worked mainly in the big setups, right from JJ Hospital. And Dr. Manisha has really told me that is where the precursor lies. Our beloved teachers, they taught us the same way what Manisha told us. Even our senior resident in before 90s, in 85, 86, they used to do the same thing what Bhartiya Valegaonkar Kulkarni used to do that moment of time. And that vigilance was always bombarded on us, and we were tuned to for the same thing. Over a period of time, when I migrated from Mumbai to Pune, almost it is 30 years now, and I came across a lot of patients which are referred, yearly at least 4-5 patients which are referred, complications which are happening in theater, and there are some complications which are mainly surgery related, or some of the complications are because of the anesthesia related, and the mainly anesthesia related complications were because of lack of facilities. That's number one. And the lack of manpower. That's number two. That is what I observed from the many of the nursing homes which patient used to refer, and many times it was really difficult to manage such cases when they patient is arrested and something is done there, then transferred here, and then we are managing, some show is created, managing something like that. That's the reason I thought that I should take this topic to talk to our colleagues. Most of the senior colleagues, they are aware of this topic, and they are vigilant also. But this culture should be inculcated in our anesthesiology practice. That's very, very important. And in today's era, I'm not going to tell anything about the global literature, what it is saying, what are the morbidities, what are the mortalities related with anesthesia, so on and so forth. But I'll try to finish up within a short period of time. What are the salient features? Basically, I'll start with the word anesthesia was coined from two Greek words. An means without, and aesthesis means the sensation. So we create a without sensation patient on the table for some period of time. Traditionally, the goal of anesthesia was described as amnesia, analgesia, and muscle relaxation. But now it is mainly anesthesia can be considered as a science of reflex management. Now, anesthetists are responsible for patient safety during operations. In my opinion, it is said that, rather I'll say, as long as patient is on the table and incision is not taken, I'm sorry, if patient is not induced, till that time the team leader or the patient is under control of surgeon. But once the patient is induced and patient is on the table and induced, the team leader is the anesthetic. That culture one has to create. Unless until each and everyone listens to the anesthetic, that moment of time, still the patient goes out of the post-operative recovery area. That till that time, it is the anesthetist's role. So I consider anesthesiology is a high risk specialty as compared with all other specialties in the medicine. Then coming to how safe is surgery and anesthesia. Today's era, a lot of patients, we are operating the patients who are 95-year-old, 99-year-old, 103-year-old, 109-year-old, and yesterday, day before yesterday, we saw the yoga guru, he was 125-year-old. So such type of patients are going to come. So today, and the comorbidities which are associated with such type of geriatric patients are very high. All 5% of surgical patients, they die within 1 year of surgery. That is because of the lifespan is so much increased and the geriatric population is coming so much so. And this I have got some from the global literature. Surgical patients over the 65 years, there's 10% deaths is recorded. And even the healthier patients, when we are operating, there are minor complications also there. And by and large, if you see more than 50 years of age when we operate, there are serious complications are noted. Then coming to our anesthesia services in medical fraternity, they are always compared with the aviation industry. And believe me, only anesthesia services are the only services which are compared to aviation industry in our medical fraternity, because globally aviation industry or aviation services are supposed to be the most safe services, and that is where the comparison is there. Why it is compared? The safety of airline travel is very, very high. Whenever there is a increased air traffic, there is a density, more takeoffs and landing with less separation between the aircraft. At the same way, practice of anesthesiology is similar like aviation. Takeoff and landing is similar to induction and recovery. I think everyone will agree with this. Increased number of surgical patients and diverse age group, which I told you already, and increased comorbidities, which I have told you. Fatal accidents and complications are still happening in spite of so many gadgets which have come into the operation theater. Now, when we talk of all these things, I'm very much interested in the last more than 10 years. I'm working on the NAB, and now we are working on the JCI. globally, this WHO and the CI, they have given some. Now, this year, we are talking only on the international patient safety goals. And what international patient safety goals? There are 6 goals which are there. I will not go into the details, but just I'll enumerate. Is identify the patients correctly. If I say in 1989, somewhere in one of the major cities in Maharashtra, a fractured neck femur patient was operated on the wrong side. And the registrar who was operating, he was so happy, I have hairline reduction and so on and so forth. But when finally it was checked, it was the opposite side. When patient come off the anesthesia, patient realized that my other limb is operated. And that moment of time, I definitely remember that case was had come to JJ hospital to review, and that registrar's registration was cancelled. This was I remember. So identify patients correctly, improve our communication has to be improved, improve effective communication. For example, for the anesthesiologist, preoperative communication with the patient is very, very, very important. Always improving the safety and high alert medicines. I'll come to that in the next pages. High alert medicines, I mean, all the medicines, they have to be leveled. I'll come. Ensure safety in surgery. Safety in surgery means right patient, right surgery, so and so forth. Reduce the risk of healthcare associated infection. That is again, I'll talk in later parts. And reduce the risk of patient resulting from the fall. These are the 6 goals which internationally they are talking. What makes anesthesia safe? Now I'll come to the point. Monitoring of the equipments is very, very important. Whichever equipments you are using, you need to monitor those equipments. Always try to use safer drugs and safer equipments, which you are tuned to use the equipment. Those equipments only you should not use those equipments if you are not tuned or you don't know how to use those equipments. Recently, I'll tell you one of the incidents.
Varsha madam, please, sorry. Varsha madam, everyone. Please mute everyone, Varsha madam.
Yes, ma'am.
Yeah. Sorry, Saleh sir. Yeah, you can continue.
Recently, one of the incidents I'll tell you, which happened in one of the MRI center. They had a MRI compatible anesthesia machine, but the anesthetist who went there, he was not tuned to work with that machine, and the little bit things were different. And suddenly he could not connect the circuit, and there was a mortality. So these incidents, they happen. So unless until safer equipments in the same, when you have used it, you know how to use that equipment, then only you should, or otherwise you should get trained to use that equipment, newer equipment which are coming, newer gadgets which are coming in our theater. Everybody has to get trained. Every now and then our advanced airway management trainings are happening. One should attend and get refreshed every time. Anesthetist has to improve their skill and knowledge continuously. And one has to work with the whatever newer guidelines and protocols are coming. And surgeon also has to improve their skills every now and then. So where the safety starts? For us, the safety starts right from the patient itself. I'll come to the what it means in the next subsequent slides. Safe equipments, I told you, anesthetist skills and surgeon skills. Then which are the mandatory things which are required for the safe practice of anesthesia? That is very, very important is pre-anesthesia checks. What is the problem with the nursing home level practice or the private practice, what they are doing? And we are getting the patients from those places after the complication. I'll give one example. Patient was posted in one of the nursing home for the spine surgery. Anesthetist was called, he was pretty senior anesthetist. He went there, he didn't know what is the patient's preoperative status. By all means, he just checked some of the investigation and started reducing. And he just checked his RS-CVS, but he didn't saw his airway at all. And he faced the difficulty in intubation. He could not do anything. Just surgeon took the incision on the trachea, and somehow endotracheal tube was put because there was no tracheostomy tube or tracheostomy instruments to do the tracheostomy, and patient was transferred ultimately we have to lose the patient from the institute. We manage somehow, but these things happen. So we need to take a lot of steps in the pre-anesthesia checkups. Safe conduct of anesthesia, that is again the whatever I'll come to in the subsequent slides. What is the safe conduct of anesthesia? Everybody knows about it. Just I am refreshing or trying to tell something. And monitoring during anesthesia and post anesthesia care. These are the salient features. But in the preoperative, then again one more point which is reduce the aspiration risk and the fasting guidelines. These are the as per the this chart. This fasting guideline formula for milk is 6 hours, breast milk is 4 hours, and clear fluid is 2 hours. Earlier it was not there when we were the trainees or resident before 90s, but now the things have changed. And for adults again it is the same 8 hours and light meal 6 hours and clear food 2 hours. But having said that, all trauma patients, pregnant patient in labor considered to be as a full stomach, that we consider. Obesity, diabetic, patient with GRD, hiatus hernia considered to be high risk for aspiration, and gastroprophylaxis has to be given, even though patient is fully fasted. Now, in preoperative, what I said is these following things we must consider in the mind, and we must check it out. Casually just see something or just go through the paper. No, you must concentrate on the major thing. Essay grading, we usually do it, but airway, classify the airway into Malampati classification. Are there, we have to keep in mind, are there any aspiration chances in this patient? Are there any allergies or any abnormal investigation with what medication patient is receiving? Nowadays, you will find a lot of patients are coming with so many medicines, antihypertensive drug, anti-diabetic drugs, anti-asthmatic drugs, so many things are there. Even though some patients are addicted these days, they are taking sedatives, hypnotic, what everything we should know before inducing the patient. What are the comorbidities? That is also very important. And then we can plan the anesthesia accordingly. After finishing the preoperative evaluation of the patient, as the anesthetic is required and grading as a ASA grade 1, 2, 3, 4, 5 and emergency, something like whatever. But counseling of the patient, counseling of the relatives, whatever possible way, in whatever language they understand is mandatory. And whatever associated risks are there, whatever associated of possible complications are going to be there, what type of anesthesia you are going to give, whether it is a regional, sedation, general, what anesthesia, and how the post of care or post of management after the anesthesia is going to be there. It has to be explained to the relatives or patient in advance during the counseling only. Then again, I'm not going to stress on this slide because everybody knows. But one thing, depending upon the patient conditions, patient age, patient willingness, one should choose the anesthesia and requirement of the anesthesia from the surgeons. Then coming to this part, this is a very important part, that all the equipments we must check properly, and the standby equipments you should have at your hand. Now this is the surgical safety checklist, which is the WHO checklist, and usually routinely each and every patient in my theater, this surgical safety checklist, and most of the accredited hospitals which are there in Maharashtra, they are following this. Varsha, can you reduce this noise which I'm getting?
Yes, sir. Done.
Okay. So sign in, time out, and sign out before induction, before incision, and before patient leaves the operation theater. This is scrupulously we are following in our theaters. I request everyone, this should be followed. All the institutional people, they must be following this, those who are accredited. But those who are, it is not that difficult to convince the surgeon, and even though surgeon, anesthetist, you know each other every day, but if you follow this practice, that things become easy. Then this has been taught from the day one for us and everyone, it is there. But these are the human errors where it can happen. So each and every syringe has to be labeled, what drugs is there, and the content of the concentration of the drug has to be labeled. That is been taught from the day one, and we must follow that. What medication errors can happen, and which are sometimes fatal to the patient? Sometimes it happens that administration of the undiluted drugs, for example, potassium, if it is given undiluted, you all of you know what it will cause: ventricular fibrillation and cardiac arrest also. Then even we know that each and every GA patient we need to give neostigmine, but without antimuscarinic drugs, if we give the neostigmine, what it will cause? It may cause severe bradycardia, asystole, atrioventricular blocks, and can be sometimes fatal. So it is mandatory to give antimuscarinic drug before giving neostigmine. Succinylcholine can cause hyperkalemia, and that's why when you are going to use succinylcholine, you should know what is the preoperative level of the patient for the potassium. Medication to which patient is allergic, you must know, otherwise you may face the anaphylaxis problem. And under anesthesia, whether patient is under regional or general anesthesia, anaphylactic reaction becomes difficult to treat when patient goes into severe lung problem. Blood is also one of the component in medicine error. So wrong blood transfusion of the blood, one has to take care with whatever guidelines for the blood transfusions are given. How to avoid then this medication error? Everyone has to be familiar with the medication you use, know clearly its indications and contraindication, administer the medication strictly according to the instruction, know the patient's history and allergy, everything which I said. Now coming to the airways. As we know, patients receiving general anesthesia have no spontaneous respiration, due to which muscle relaxation, the respiration is controlled by machines via endotracheal tube. So we must ensure oxygen supply and avoid accidental activation during surgeries, especially in a prone position. What I wanted to stress here is sometimes it happens that in the institutional practice, there are resident doctors and we say we have intubated, just check the airway. But as a team leader or the chief anesthetist who is intubating, he has to personally see that airway, endotracheal tube is properly placed, air entry is equal on bilateral sides, and when particularly prone position is given, after prone position, air entry has to be checked. There are chances that accidental extubation of the endotracheal tube may happen, tube may come out of the larynx, that has to be checked properly. How to avoid this? Again, the same thing, check the system and it's functioning well. I told you endotracheal tube and fix the tube solidity, so and so forth. There are certain procedure errors also which occur. I am just taking some salient feature, 8-1 intravascular injection. I'll tell you one story. 13-year-old boy coming in the casualty with some CLW, and the intern tries to give the local but inadvertently injection to the vessel. Intravascular injection, boy starts convulsing just to take the sutures. The anesthetist rushed somehow and the things were managed, and the casualty medical officer can sedate the patient and things were under control. This happens. So for us, what is the message from this is every time we need to aspirate and then give the block. That is what we said, that when you are giving the blocks, particularly nerve block, that time stop, you confirm everything and then inject. Stop, confirm everything, then inject. Epidural hematomas may develop, but when spinal or epidural anesthetics are performed in patients who have coagulopathies, whenever patients are coming with the coagulopathies, patient is on some drugs, when to give and when not to give the regional anesthesia, that has to be confirmed by all means. Air embolisms while placing or removal of the central catheter, we have to be very vigilant about that. standards for basic anesthetic monitoring. I'm coming to some perioperative monitoring level, intraoperative monitoring level. That is, all these multipara monitors are there everywhere now. You should monitor respiration, respiratory system, cardiac system, and temperature, which are very, very cardinal, where we monitor the SpO2, EtCO2, ECG, blood pressure, pulse, and CVP if CVP line is there. But temperature monitoring is also very, very, very essential. Then coming back to the which are the common causes for complications, mainly which we have noticed is the system failures are the main reasons for the accidents. So before inducing the patient, check the systems are in place properly. Check your anesthesia station which is working properly, oxygen supply, backup oxygen supply. Your monitors sounds are properly audible. Patient has got before induction any diseases, whatever like hyperthyroidism, thyroid storm may occur. Diabetes, the patient is diabetic ketoacidosis or hyperosmolar coma. These things you have to keep in mind. Human factors affecting the performance such as fatigue, noise, boredom, long hours of and hunger, tension. This again I'll come back in human errors, or the particularly concerned with the anesthetist and surgeon. These human errors are also a strong contributor of the anesthesia complications, one has to keep in mind. And when you are changing, when you are planned after preoperative evaluation, everything that anesthesia so and so will be planned and will be giving, but suddenly sometimes you have to change, or your this thing regional has got over and you are changing over to general anesthesia. At that moment of time in hurry, something may miss, something may happen. So you have to keep prepared everything beforehand. And as always said, lapses in vigilance and no attention to details. Vigilance is very, very important. That may lead to. Which are the common, these are the common complications which everybody is aware of. These common complications up to the cardiac arrest, common complications are noted and these things have happened. Then these are the causes of the cardiac arrest. Sometimes it is drug overdose, rhythm disturbance, perioperative MI patients, or airway obstruction, high level of spinal, lack of vigilance is very important. Bleeding, overdoses of inhalation agents, aspiration, tracheal problems, anesthesia. So see this picture, this everybody is vigilant. She is doing something, anesthetic, main anesthetic is doing, probably she's putting the central line and someone is assisting, but other people are also vigilant. So you have to be highly vigilant during whatever procedure you are doing in the theater. Now coming back to the one of the another intraoperative monitoring, as I was stressing on the temperature, hypothermia. In these days, theaters are very, very chilled. People are doing high-end surgeries in neurosurgeries and transplant surgery. They required sometime temperature from 16 to 18 degrees centigrade. And that moment of time, really patient goes into hypothermia, and we have to be vigilant. Nowadays, the gadgets are there. All tertiary care hospitals, probably, I think, fluid warmers and patient warmers are there. They are using it, but if in the small setup these things are done, and particularly winter season where the ACs are very strong, one has to be very, very cautious about the temperature monitoring, how to monitor. All these modular cardiac monitors are there nowadays. You can have a temperature monitoring system. You can assist your surgeons to get that. So what it will lead to hypothermia, what it leads to, shivering, oxygen requirement is increased because shivering, myocardial oxygen supply is increased, demand is increased, and hypothermia, it is said that it leads to directly indirectly to the infection, post-op infection, because immune system function is depresses, vasoconstriction occurs, and because of that reduced tissue oxygenation, which reduces infection. This may lead to delayed wound healing, and there might be sometimes bleeding and transfusion may require, depressed platelet and coagulation, depressed cardiac function and risk for the arrhythmias is there. So delayed recovery from anesthesia for us, this is again a very important. Hypothermic patients, we must have witnessed many times that hypothermic patients delayed recovery is there. So we need sometimes need to bring the temperature to normal temperature. So having said all these things, how to take precautions, so many things. If something goes wrong, what we should do? If something goes wrong, happens wrong, urgently, first implementing time buying measures. For example, you need to time buy, something has to be done. Increase the fraction of the inspired oxygen when oxygen saturation falls, administered in intravenous fluids, vasopressors when hypotension is there, and then search out any correctable primary cause and treat it appropriately. And after that, immediately prepare for crisis if there is going to be a crisis. What we have been taught in crisis, we immediately need to ask for the help. And whoever is there, if there is any critical event happen, for example, might be a cardiac arrest or anything else, call for the help. Then use accepted protocol in all the theater. Even though it's a small nursing home, you should have your protocols written down and mounted on the wall, that these are the protocols, CPR protocols, who is going to help, who is going to come, what surgeon is supposed to do, what assistant surgeon is supposed to do, and what anesthetist is supposed to do. This has to be protocolized, and then the things become easy for the anesthetist. Otherwise, there is no help. And I'll request everyone, all the anesthetists, periodically they should undergo training for advanced ACLS training. They must undergo. Even though we are doing n number of programs for course activities, but some of the anesthetists, they are not undergoing this advanced life support training, and they should rather, my request is they should undergo this training so that they are always vigilant, or they are enough competent to do the CPR at small places also when they are doing the cases. Still in today's era, in spite of all these things, all these facilities available, we people, our colleagues, they are traveling. Just now we saw our Honorable Secretary is traveling 15 kilometers from his headquarters to give the anesthesia to cesarean section. In communicate again, we need to enhance the teamwork and communication system. And whenever we are calling for the help, that anesthetist should be available that moment of time. And that communication system, if someone is not available that moment of time, if somebody calls me, Dr. Sade, are you coming? I am in a crisis. But if I am not in a position, it is my duty to inform all our colleagues who are there free to attend this particular XYZ, wherever the person, our colleague, is in problem. That communication system has to be developed. And how to develop in that area, that is again a call for those. Now all these societies are active, and our society members should take this type of situation. Where we in Pune city, in this area, we have tried to take this way. Means if something goes wrong in some place, whoever is free rushes to that place. And the communication, the person who gets the call, it is his or her duty to communicate all other people. Whoever is free should reach that place. Then now coming back to the end, anesthetist is a stressful job. Anesthesia is a stressful job. If you feel very tired, what I was trying to tell about the human errors, ask for the relief. You hand over the case. You give that case to someone, to your colleagues from your team or whoever is there. But if you are tired, don't attend that patient or give that case to someone else. Somebody will do it comfortably if you are tired and stressful. In the theater, if there are various stressors like noise is there, you have to reduce that noise. Then if you are fatigued, as I said, you should call for the help. Interpersonal tensions, you should, etc., you should forget and try to avoid all those things in the theater. Work environment has to be optimized. How to optimize in the work environment in the institute or in the small place or in the remote place, that is again everybody's call. Patient safety must remain the highest priority, because you cannot compromise in all these situations patient safety. In certain hospitals or in the big hospitals, anesthetists have a great deal of workload, big workload, very heavy list. Sometimes morning 7 o'clock, 8 o'clock list starts, and it goes up to sometimes 9 o'clock, 8 o'clock, and still emergency starts coming, and they have to attend the emergencies also. So anytime we can't sacrifice patient safety in order to emphasize the production. Sometimes management has down these number of cases, whatever list is there, you people have to finish up. But when you are exhausted, you comfortably you should say that this team will take over now. Accordingly, one has to manage, and the heads of that institute should take care of these things. Now, learn from the close call. Every mistake is an opportunity to learn and improve, and analysis and feedback of adverse events to identify, assess system problem. See, some or other time, we have faced such type of incidences. Everybody must have faced some major or minor, but that should be discussed, and that should be, that's a learning lesson. If something has gone wrong from my side while injecting the drugs, then that's a lesson for me, and I should discuss, and what mistake I made, it should be known to others also, so that people will understand, Dr. Sade has made the mistake, I should learn from this mistake. All said and done, the aim of improving the quality of care and minimizing the risk of injury for the anesthesia. What is this quality assurance is? We must give the safe anesthesia to our patient, wherein patient satisfactory index is supposed to be very high. At the end, when patient is going home, patient should realize that he doesn't have any memories of his surgery. And whenever such type of incidences happen, documentation is highly important, and subsequently, whenever such type of incidents happen, you never talk anything about that. Your document should talk about it. And whatever guidelines are set by your small organization or major big organization or small setup, these standard guidelines, or if they are not there, you please set up the guidelines of giving anesthesia services to that small nursing home or smaller setup or a big setup. You should have your own guidelines, and everybody has to work in the same guidelines. You can set up your own protocols, you can set up your guidelines, and convince the surgeon, counsel the surgeon to set up these guidelines. Safety training, there are a lot of safety trainings besides anesthesia training. All those critical safety training, whether some incidents has happened, then for just example, I'll quote you how to use the fire extinguisher. We should know if something goes wrong in the theater or wherever you are there, you should know how to use that fire extinguisher. This is one of the safety, and how to take out the patient from the theater to outside. That is also one of the safety training. All the basic skills of the safety training, whatever the institute or the small or big setup, they are creating the safety training that anesthetist has to attend and has to learn all the safety skills for the organization. Now I have in between, I have talked all these things. Now coming to the post anesthesia care, when you are shifting the patient from the OT to post anesthesia care unit, that time you have to do the timeout. Means by all means, anesthetist is responsible medico-legally till the 30 days of your surgery and anesthesia. Don't consider that only patient is gone to the recovery ward and patient is okay, fine. No, there are certain issues which are there. You have to be vigilant. Patient may come back within the 30 days. It is considered to be anesthetist is also equally responsible. So while setting up the PACU post anesthesia care unit, you need to have a proper facilities in the nursing home. At least one bed where you can keep the patient and you can observe for some time, or monitoring system has to be there. When you are doing a second case in the theater, again in the same place, but outside, somebody who is trained personnel has to be there to monitor the patient. And monitoring devices have to be there in the post-operative area. And in the post-operative area, you need to take pain relief for the patient with the multimodal analgesia, and you have to send the patient from your recovery or your small place with I will advise to have a modified alternate score from PACU. That score is available on the Google. You can download, you can start practicing with that score and sign that score and then send the patient to your respective wards or units. Then this is antibiotic prophylaxis, hand hygiene, glycemic control. This is all for post-operative infection. If patient comes within the period of 30 days, they will check whether the prophylactic antibiotic was given or not given. How long was the surgery and what time it was repeated. Throughout the glycemic control was there or not there. Everything will be checked properly. So this responsibility remains with the anesthetist. As beginning only I said, when the patient is induced, it is the team leader is the anesthesiologist. So all these roles are anesthetist roles. So try to avoid the hypothermia and fluid and blood products or whatever necessary you need to give properly. Proper fluid replacement and blood replacement therapy has to be done. Aseptic precaution for all the practical purpose has to be taken, and need to avoid the hypoxia and hyperoxia. Thank you so much. I tried to finish up this with the salient picture. Might have taken some more time. I don't know. Thank you so much. Thank you, Silpa and whole Borivali ISA team. Long live ISA. Thank you so much.
Sir, it was such an excellent talk and covering every small point. Every slide had something new. Yes, I should look into it. And thank you so much, sir. Yeah, over to you, Priya madam.
Yes, ma'am.
Priya madam, yeah, over to you.
Thank you so much, Sai sir, for such an informative talk on a very, very important topic, sir. As sir said, effective communication and a protocol-based practice and a team leader as an anesthesiologist is the key for safety in the OT and even anesthesia outside the OT. Sir has shared with us examples which are the take-home messages for all of us. Thank you once again, sir.
Thank you, lovely guys.
Shilpa ma'am?
Yeah, Priya madam, continue.
Okay. Please put your queries or questions in the chat box so we can learn more from the experts.
Actually, sir covered every aspect, but still, yeah, those who have queries. Meantime, Priya madam, would you like to introduce our next speaker?
Okay, ma'am. It's my pleasure to invite Dr. Kalpesh Shah, sir. Sir is a consultant anesthesiologist practicing in Mumbai for the past 20 years. Sir is also the director at Safe Anesthesia Solutions and Plexus Anesthesia Solutions. Sir has been certified by the Indian Association of Palliative Care, and today Sir will be sharing his experience in the role of an anesthesiologist in palliative care.
Varsha madam, can we have the certificate? Can we have the certificate, Varsha madam?
Yes, ma'am.
Um, Varsha madam, actually, you have projected Charushila madam's certificate. I just got a call from Kalpesh sir. Sir will take another 10 minutes. Neelam madam, are you there? Neelam madam?
हॅलो
तुम्ही आहात का?
मी आहे पण सॉरी आय हॅव टू जॉईन फ्रॉम माय लॅपटॉप नाव because I have to do the screen sharing. It will take 2 minutes.
Okay, we can wait for 2 minutes. Meantime, anyone wants to share their experience regarding the safety? Yeah, today I see many new faces from ISA Borivali, new names from ISA Borivali, though everyone's video is not on. Avinash sir, do you want to share something? In private practice, we usually, now I'm in a semi-institute, but initially in private practice, we used to directly come, immediately everything is to be ready, induce the patient. Of course, check everything, but still, there used to be a small time factor.
If I may, madam, may I just share a small experience?
Yeah, please go ahead.
Yeah, this is regarding, what Manish madam had said initially. This is during my training process when I've done my MD from San Hospital. So as we were junior residents there, we had a very senior madam who used to always tell us, keep a hand on pulse. We did not have monitors in every OT at that time. And, initially as juniors, we found this very annoying. We were some 3-4 juniors, keep a hand on pulse, keep a hand on pulse. We never really took it very seriously. Until one day we had a small patient for an incision drainage. There was a small abscess on the palm, but the patient was probably in impending septicemia. And then we had to give position to the patient, slightly extend the arm. And as the surgeons were preparing, since luckily one of us had a hand on pulse, we realized that the patient had arrested. Yeah, because of the impending septicemia. And since there was no monitor, then suddenly that junior said, Madam, mala pulse tata lagat nahi. And then we all realized that there is some problem, but the patient was young, so we immediately could manage to resuscitate the patient. This is how we realized the importance at that time and on that day. Initially, we used to all get really annoyed. Kya hand on pulse, madam? 3-4 jane, kya hand on pulse? But that was one day when we realized that if we did not have the hand on pulse that day, we would have really lost a young patient. It would have taken a few seconds to maybe, even a few minutes for us to realize that the patient had stopped breathing or the patient did not have a pulse. So this is what, when Manisha madam told her experience, I was, taken back so many years ago when we had experienced a similar thing. And so these small things that, as even Sare sir has said, we tend to take these things for granted. We've been doing this, circuit kya check karne ka, drugs kya dekhne ka. But it is really very important, sir. So back to basics was really great. And thanks for emphasizing on all that, sir. That's all I have to say.
Yeah, thank you, madam. Today we have Jessie madam who has joined with us, President IIC Navi Mumbai. Madam, I saw your name. You are there? Jessie madam? And of course, with the khazana of lot of cases, Dr. Rao sir and Dr. Mahendra Kamdar sir. Kamdar sir, meantime, Neelam madam gets ready and Kalpesh sir is free. Do you want to share your experience about the safety? Yeah, Neelam madam.
Yes, I'm ready. Yes. Varsha, can you?
मॅडम परत म्यूट झालात तुम्ही मॅडम अनम्यूट करा नीलम मॅडम
Yes.
Neelam, you are muted.
वर्षा मॅडम अनम्यूट नीलम मॅडम
No, I am talking with Varsha about sharing my screen, so I have muted myself. Just give me 1 minute.
तोपर्यंत कामदार सर हाउ आर यू नाइस टू सी यू एखादा छोटासा
I just wanted to say one thing. I mean, the speaker talks so well, but I can tell you in last almost 50 years of my experience, in spite of doing all those things, the accident will keep on happening. Because whether it is an error mistake, whether it is because of the equipment problems, whether it is because of the other facilities available, not available, whether you are tired or you are not confident enough to conduct the case, whatever may be the reason. As he said, we can do, in spite of following all the protocols, the cases keep on, the accidents keep on happening. So we have to accept it. Only thing, we must find out how to minimize that thing. That's all.
Yes, sir. Accidents are still happening, still on a rise, but accident rate has come down. With global analysis, we in Indian scenario don't analyze much, but global analysis from 11.8 it has come down to almost 4 point something. That is the rate.
I do agree with you. I do agree with you that things are improving because of so many gadgets available, so many other facilities available, infrastructures improving and things like that. But still, there are cases where I'm sure every 2-3 months we hear something or the other where some problem has taken somewhere. Maybe the things may come out positively or we may come out of the problem and all. But these problems do occur.
Yes.
Only I can tell you, I was conducting a case where I had given a segmental spinal, which I have been giving regularly, and today, to my surprise, it did not act properly, in spite of my all possible precautions, whatever you say. But I had tough time to manage the whole case. Of course, I managed somehow the other managed to finish the case. But what I am trying to say, in spite of using the correct drug, in spite of using the correct equipment, in spite of using the correct dose, everything was perfect. In spite of that, it did not act properly. Now, I don't know how do I explain. So what I am trying to say that yes, in spite of following all the protocols, still the things go wrong. And we have to accept that thing. That's all.
Nowadays, sir, we are monitoring the monitors and not the patient. In previous year,
No, I
back,
disagree.
there was...
I disagree with
Hello.
you. We do monitor the patients. Just because there are monitors does not mean that we do not look at the patients. On the contrary, we are extra cautious about the monitor and the patients both. I think it's a wrong belief that we don't, because of the monitor, we ignore the patients. No, it is not so.
We should monitor both patient and monitor also. Just
Exactly,
we are hearing the alarm sounds and
exactly.
Yeah.
So you did
At
not.
that time, we were watching the respiration, pulse, BP, bleeding,
Exactly.
all things we are watching.
You are absolutely right. That's what I'm telling you. That by today's case only, the things were going wrong. It did not act properly. I had to supplement. I had to give sedation. I had to give. Kept on giving sedation, and also my adrenaline had. The adrenaline secretion in my body was tremendous. I was worried about the patient because patient was very short, obese patient, short neck, and even little more sedation and patient starts snoring. So kept on watching about the oxygen saturation and pulse and blood pressure and all. So what I am trying to say, in spite of taking all the precautions, following all the protocols, things do go wrong. And we have to accept that thing.
Okay, sir. Avinash, sir, you want to share some experience? You were talking about some experience. तुम्हाला काय सांगायचं होतं का?
Hello.
You were telling about something, right?
No, I'm just start
Hello.
with.
This is not moving now.
Yes.
Neelam madam, you can start.
Yes, I'm starting. So my topic for today is multimodal pain management. multimodal analgesia practices in private practice, why, when, and how. So in next 20 minutes, we are going to just try to see answers for these questions. Why we have to use multimodal analgesia, when we have to use it, and how we have to use it. So before addressing these questions, I would like to just address one question. What is multimodal analgesia? So, multimodal pain management by definition is combination of two or more analgesics that act at different mechanisms and produce an additive or synergistic analgesia. So what is additive analgesia? The action of the sum effect of both the drugs is same when given individually. And what is the synergistic action? Is the action of both the drugs is superior to when given individually. That is 2 plus 2 is 4. So the action of both the drugs when given together is more than when they are given single. So advantages of multimodal analgesia are it improves the analgesia, it lowers the dose of individual analgesics, it reduces the side effects. In turn, it helps in early mobilization, early enteral feeding, rapid recovery, and low cost. Advantages continue as reduction in pain intensity score, opioid sparing effect, reduction in opioid side effects, and early recovery and improvement in surgical outcomes. So pain is so important, and we all feel that we are managing our patients very well. We are giving whatever analgesics are required, and our patients are always happy post-operatively. So how is the scenario at present? How are we treating our patients post-operatively for analgesia point of view? So here are a few studies here. So in the very recent study which was conducted in 2014 on a very large number of patients, really had very shocking conclusions. And it said that 86% patients post-operatively experience pain. And out of this 86% patients, 76% patients complain of moderate to severe pain. So this, I feel, was a very shocking conclusion of this study, and we really need to start thinking about management of post-operative pain in a very meticulous and aggressive way. So now what are the consequences of inadequate pain control? So if we see in this slide, I think inadequate pain control will affect all the systems and cause undesirable effects. But I would like to really stress upon the persistent post-surgical pain and chronic post-surgical pain. What happens when we treat pain inadequately? The two more main worrisome things are hyperalgesia and allodynia. So what is hyperalgesia? So there is a sensitization to pain stimulus at peripheral or central level. So what it causes? It causes perception of mild pain as very severe pain. That is hyperalgesia. And what is allodynia? Allodynia is there is central sensitization in such a way that initially there is no pain perception. That stimulus is perceived as pain. Like for example, touch is perceived as pain by the patient. So these two conditions, hyperalgesia and allodynia, are really, really worrisome if we are treating pain inadequately post-operatively. Also, this slide will show how this is actually a total of multiple studies which show how acute pain can lead to chronic pain. And just see regularly done surgeries like amputation, breast surgery, and all incidence of chronic pain in these patients is as high as 30% to 50%. The most worrying part is the circle, red circle, which shows disabling pain. What is disabling pain? Is chronic pain in which patient is not able to do day-to-day activities. So this pain is as high as 50%, as high as 10% in this regular surgeries, such as inguinal hernia, breast surgery, amputation, where we feel that we are really giving optimum analgesics in this type of patients. Other consequences of inadequate pain control are delayed recovery, increased duration of hospital stay, increased healthcare costs, reduced patient satisfaction. And I feel for all of us, it is damage of our image as a perioperative pain consultant. So now why it is so difficult to treat pain? What is the actual problem? Why we are not able to treat the pain? So if we see the characteristic of pain, it has very different modes and facets to it. If we see this slide, it will just show us in short that pain is very multifactorial and multifaceted. So if this is the nature of the pain, how one drug can act on uh, all these factors which are causing pain for us. So this demands that we know how the pain travels in a patient, so that we know where to target the pain and where to give drugs so that our patient will be pain free. And for this, in very short, we need to know pain pathway. I can find the most simplest diagram which I can search on Google was this, and I will try to make it more simple. So there are 4 stations where pain is perceived in our body. First is where the site of injury occurs or tissue insult occurs in our body. This is transduction. So what happens when there is an insult in our body or we are taking an incision on patient's body? There is no pain, but the changes in the thermal and pressure sensations will release chemical mediators like prostaglandin and histamine, and all these mediators, they will give signals to the nerve endings. So this is the first station of transduction, where we are going to, this is the first station of pain, that is transduction, where chemical mediators are released. So second station will be transmission. So what happens, these signals which these chemical mediators give to nerve, the nerve converts it into action potential and transmits them to the spinal cord. So second station will be transmission, where we can hit the pain. Third station is spine. So in spine, these signals come through the nerves and they come to the dorsal horn of the spine. So this is modulation. So what is modulation? Very important characteristic of pain pathway happens here in the dorsal horn of the spine, and that is it inhibits or exaggerates the signals of the pain. So modulation of the signals occur at the dorsal horn of the spine, and further the signals are transmitted to the brain. And at brain, the signals are perceived. The signals are perceived as pain. So this perceiving signals at brain is the most important thing. Why? See now how the pain is perceived at brain will depend on so many factors, as you can see in this slide: genetic, demographic, social factors, associated comorbidities, previous experiences of the patient, how much tissue is damaged, how much nerves are involved. So all these factors will decide how the brain is going to perceive the pain. So again, coming to this slide, what is the importance of these factors? So the same amount of tissue insult in different patients will be perceived as different degree of pain by each and every individual. So that is importance of all these factors, how the patient is going to perceive pain. And these factors vary so much that this demand for a tailor-made plan of post-operative pain in each and every patient. This is again the same slide. We can skip it. This is same slide. This was for me while preparing the slides. Okay. So only one thing, if you want to take from this talk, will be this slide. This is a pain pathway with 4 stations and 4 group of drugs which will hit the pain pathway at these different stations. So first is transduction. The group of drug which acts here is local anesthetics by infiltration of the incision, paracetamol, and anti-inflammatory agents. So how these drugs act at this place or this site of the pain pathway is the chemical mediators released are inhibited, mainly the prostaglandin is inhibited, and the action potential which is formed by prostaglandins, which is carried by the nerve ending, is cut off here. So these drugs act peripherally by inhibiting prostaglandin. The second station will be the transmission by the nerve fibers. So here, if we give a local anesthetic agent, we can block the transmission of this action potential from the site of injury to the spinal cord. So local anesthetics can be given to block the transmission of this signal. The third station will be the dorsal horn of the spinal cord. Drug acting here are local anesthetics, opioids. Alpha-2 agonists are mainly clonidine and dexmed. They usually are not used as first choice of anesthetics, and here they are analgesics, and here they are mainly used as adjuvants for central neuraxial block. NMD antagonist I will cover in central one. So one more advantage of this dorsal horn is in pediatric patient, the inhibitory pathway in dorsal horn is not very well developed. Only aggravated pathway is developed. So if we don't treat acute pain in pediatric age group, the pain is really rewired, and the next experience of pain is more aggravated in pediatric patients. So now if we see the fourth group of drugs, is opioids, alpha-2 agonist, paracetamol. Paracet is one drug which will act locally as well as centrally. NMD antagonists are ketamine and magnesium sulfate, and anticonvulsants. So anticonvulsants are used in multimodal anesthesia, where sometimes they are given in preemptive stage, so that they can help in opioid reduction, and they can help in quality of anesthesia. But worrisome thing is the sedation. So if we are not comfortable giving these drugs on previous night, we can give it 2 hours before the surgery, because the drugs take around 2 hours to reach the plasma concentration. So these are 4 group of drugs. These are 4 stations in pain pathways. And now this is the basic of multimodal pain management. So what you have to do is you select one drug from each group, so that will act as synergistic to each other. Like if you select non-steroidal anti-inflammatory drug along with opioid, non-steroidal anti-inflammatory drugs like diclofenac, it will reduce opioid requirement by as high as 50%. Major more commonly used in diclofenac, the dose is 75 milligram twice a day. We should not exceed it more than 150 milligram per day. It is available. IM, IV, and suppositories also, not to be given in kids less than 4 years. And usually they worry about peptic ulcer bleeding and renal failure, but it is said that short duration use of these drugs usually don't cause these issues if the patient is not having renal or bleeding risk factors. But it is always wise to give them along with PPI drugs like PAN40 or something. Then again, local anesthetic. Local anesthetic is one drug which acts everywhere, like peripherally you can give by infiltration, you can block the nerves, you can give central neuraxial block, you can give IV infusions by which it will act centrally. Other drugs are used as adjuvants in this multimodal therapy. So now this is the main pathway, how we are going to use it. Is there any guideline, like if I'm going to use multimodal, how can somebody help me with this? So I'll just like to share a few slides. This is WHO pain ladder. Initially, it was formed for treatment of cancer pains, but later over years, multiple modifications were done, and now this system is used for treating acute post-op pain. So the first step is for mild pain, second is for moderate, and third is for severe. Here, advantage is you can directly jump to the third step if your patient is having severe pain. So this, many people follow these guidelines. Another old way, opioid was first choice of drug in analgesia. Now regionals, paracetamol and NSAIDs have become the first choice. In fact, American Society of Anesthesia, where they have formed guidelines, they have said that we have to use paracetamol round the clock in all the patients if possible. Okay, so I was talking about these guidelines. They were formed in 2016 by American Society of Anesthesiologists Committee along with other societies. And they have put around 30 to 32 points, but you can just go on Google it and read it if you want. I'll just tell you the highlights of this guidelines. This guideline says that you have to use different group agents, that is different group drugs or different approaches as part of multimodal analgesia. You have to plan a individualized plan pre-operatively, in pre-op visit only. It has to be tailor-made per patient, per surgery, and expected intensity of the pain. Here again, what I was talking about, the same thing, analgesics such as paracetamol and NSAID should be given round the clock. Regional such as nerve blocks and epidural should be part of multimodal analgesia. This is my favorite, and I think many of us in Borivali are using this shoe mix regularly. This was invented, I would say, by Dr. Shiv Kumar, and this is very popular in private practitioners. This, along with giving good analgesia, is also opioid free, and it will have more advantage if we give this mixture preemptively, that is before the incision. Preemptive analgesia is we give drugs before the incision. Why we give before the incision? Because if you are blocking the pain pathway at transduction, that is at the tissue insult, there won't be any chemical mediators released. So there won't be any pain traveling towards the spinal cord or the central brain to perceive. So preemptive analgesia really works well rather than post-operative analgesia planning. So now we have all pain pathway we are knowing, all the drugs which will act on various levels at pain pathway we are knowing. We are knowing all the regional where we can hit the transmission of the pain pathway. So now how can we use these multimodal drugs in our private practice day-to-day anesthesia where we are doing routine surgery? So I've just mentioned few surgeries where what we regularly give and how we can add multimodal analgesia to it to give a superior quality of analgesia in these patients. So regularly tonsillectomy is where we give, usually local infiltration is better. They are very painful, so 1% adrenalized halogen. Here the beautiful part is any local infiltrated before the incision will give action for more time than the local infiltrate after the incision. And also it makes sense because if you use it before the incision, you are inhibiting the chemical mediators from releasing. So you not only in tonsil, in other surgeries also, it is wise to use local infiltration before the incision. So 1% adrenalized halogen is given, which will help to create the plane also. A single dose of dexamethasone. Now dexamethasone is very favorite drug. Some people regularly use 4 milligram of dexamethasone at induction. It reduces the opioid requirements. It is it helps in analgesia. It reduces post-op nausea, vomiting. So a single dose of dexamethasone can be added to all surgeries. Also, usually we give either paracetamol or NSAIDs. In multimodal analgesia, what we can do is we can give IV paracetamol and we can pass a diclofenac suppository if the kid is more than 4 years. Or if we are giving IV NSAIDs, we can give a paracetamol suppository in these kids. Second surgery, usually this I have mentioned piles, usually done under saddle block and Zonac suppository for post-op analgesia. Multimodal analgesia part can be topical agents can be given as part of analgesia. Perineal block can be used as a regional which can help in pain relief in hemorrhoids. Also IV paracetamol or Shiv Kumar mix 1, that is IV paracetamol with tramadol can be used as part of multimodal analgesia. So these recipes can vary according person to person. We know the ingredients, now we can form our own recipe. Colorectal surgeries. My favorite mode usually is epidural. To give an epidural dose before starting the surgery, continue it intraoperatively, and then continue the same infusion post-operatively. Fentanyl patch is applied at the induction because the surgeries take very long and it starts acting at end of the surgery. Dexmed infusion, if you are planning to use the bolus, better you give before intubation. That will help, and continue it in the intraoperative period. If you feel it should be part of the multimodal analgesia, continue dexmed infusion post-operatively also. As per guidelines, paracetamol we have to use around the clock. Remember, maximum dose is 4 grams to be given in 24 hours. Breakthrough pains can be tackled with diclofenac, that is 75 2 doses, or SOS, Nalfi, Tramadol, whatever you feel appropriate for that patient you can use. Some people use epidural morphine or pre-op shoe mix, intraoperative dexam, that we have already said. Okay, this I would like to stress upon is quadrant tab block. So what is quadrant tab block? In very intensive abdominal surgeries where you are not able to pass epidural catheter for any reason, to tackle the pain of the incision, what you can do is you can give tab block in 4 areas. That is just below the costal margin on both the sides, just above the iliac crest on both the sides. So this quadrant tab block can form a very good part of multimodal analgesia and colorectal surgeries. One thing to remember here is volume of the local anesthetic. So you just calculate the dose and make a solution of 2 milligram per kg of Sensocam, and then adjust the volume of the drug accordingly, and don't exceed the required dose for that individual patient. Laparoscopic surgeries usually shoe mix is used before induction. Port infiltration, as again I would insist, to be done before the incision. NSAIDs form an important part in post-op pain management. And as a part of multimodal analgesia, intraperitoneal local instillation, it really works well. Before removing the ports, if you instill local anesthetic intraperitoneally, patients are really very comfortable. If lap cholecystectomy for some reason is converted into open, then the open cholecystectomy, infiltration of the incision is preferred over the costal tab block or rectus sheath block. Why it makes sense is because usually the incision is taken between 2 ports which they are applying. The medial port is usually at the center. So there is no point in giving one-sided rectus sheath block, because again there will be a port pain which is causing a problem to the patient because the nerves are overlapping from the other side. So instead of giving a rectus sheath block for open cholecystectomy converted after lap call, it is wise to just infiltrate the incision. TKRs are favorite, and there are so many studies done for TKR and THR, and so many different combinations are available. And I think everybody, I don't know, somehow I feel whoever I talk to is using something different only for TKR. Usually what I do is spinal is given with local and some additive like clonion, and epidural or femoral catheter is passed. Our surgeons usually have a urinary catheter for the patient and they don't mobilize the patients early. So I am okay with that. Paracetamol is given round the clock, and NSAIDs are given for breakthrough pain. Here again, if the patient is not comfortable with epidural or femoral infusion, instead of increasing the local anesthetic concentration, wise will be to add a fentanyl to the infusion, epidural infusion, and that will give superior quality of pain. Surgeons which insist on earlier ambulation in TKR patients, usually simple plain spinal anesthesia is given, which is supplemented with block or pericapsular infiltrated, and again NSAIDs. Some regularly give adductor canal block for TKR pain. Laminectomy, simple laminectomy, usually what we do is shoe mix before induction, fentanyl patch, and wound infiltration after the laminectomies. And breakthrough pain, or if the patient still complains of pain, paracetamol or tramadol. NSAIDs, usually we give 1 dose of dexamethasone that surgeon only requests us to give. One more part of multimodal analgesia which can be added to laminectomies can be, we can request the surgeon to deposit some local anesthetic at the epidural area before the closure of the bone. Fusion and scoliosis correction. These are usually extensive surgeries, usually in young kids, and they are very, very painful surgeries. So usually they are conducted with the pre-op shoe mix, intraoperative dexmed infusion, and we usually use IV fentanyl infusion in ICU for these patients, and the dose is titrated as per the patient's requirement. Paracetamol is given round the clock. Again, multimodal analgesia part can be applied here with epidural deposition of local anesthetics and NSAIDs SOS as per requirement of the patient. Hernia. Usually hernia we do under spinal anesthesia and post-op non-inflammatory, some drug like diclofenac is added. Part of multimodal analgesia for hernia, like we saw how many patients of hernia are treated inadequately for acute pain, get converted into chronic pain, and some even have disabling pain. So multimodal analgesia approach is paracetamol, classical hernia block, ilioinguinal nerve block, TAP block. And one more thing is, while they are dissecting the cord, instead of saline, they can use local anesthetic, which can later help for pain management. In kids, usually Elmacam is applied on both hands. Dexcade is a very popular combination in kids for short surgeries, but it is always wise to use local infiltration at the surgical incision, suppositories, and if you are doing it under regional, caudal will be a best option for hernia and circumcision patients. For cleft lip, usually we give suppositories and blocks. While finishing the surgery, usually for cleft lip patients, we are giving block. In multimodal analgesia, it is suggested that in these patients, you can give single dose of Dexped with a dose of 0.2 milligram per kg at extubation, and this makes the kids really quiet and they don't cry. I have not yet used, but I would like to use this. So this is the end of this talk. So what is multimodal analgesia? In conclusion, it is striking a balance between providing effective analgesia and preventing the side effects of analgesics. Thank you so much.
Thank you, Neelam madam. It was such a nice presentation. Over to you, Priya madam.
Yes, ma'am. An excellent presentation by Neelam ma'am.
I will stop sharing, Priya.
Yes,
I will click stop share. Yeah.
It's an eye-opener for all of us for improving our analgesia and pain management practices intraoperatively as well as post-operatively. Thank you, ma'am, for sharing these examples. I think we have a lot of questions.
Are we taking questions now or after Dr. Kalpesh's lecture?
Whatever you say, whatever Priya madam, whatever.
Kalpesh sir is waiting.
Yeah, Kalpesh sir is waiting. I think we'll finish.
Yes, I think we will
I'm
finish
ready,
his
I'm
lecture.
ready.
Yes.
Okay.
Yes, madam.
Busy
I'm ready.
we can.
I'm ready, madam.
Yeah. Varsha madam, can you project Kalpesh sir's certificate, please? Kalpesh sir, seeing you after so many days.
So many days, yeah. I'm not able to share my screen. Can I?
Okay. Varsha madam, जरा help कराल का? आहात का तुम्ही?
Yes, ma'am. Yes.
सांगा ना त्यांना. Kalpesh sir, you have kept your slideshow open in your laptop?
I don't think so. No, slides.
Slideshow open करो ना. We are less than 100. You want to वर्षा मॅडम त्यांना एक्झिट करावं लागेल का आणि मग
नाही मॅम एक्झिट करायची गरज नाहीये. कल्पेश सर जस्ट ओपन स्लाइड शो. मिस जस्ट पीपीटी ओपन.
वर्षा
आपने क्या ओपन है?
कल्पेश सर ओपन किया अपने पीपीटी. Kalpesh sir.
Sir, you are mute.
Okay, mute. Right.
आपने वो पीपीटी ओपन की क्या?
पीपीटी ओपन किया हुआ है. I'm trying.
अभी नीचे शेयर स्क्रीन. Yes, हो गए.
Can you see it now?
Yes. Just click from beginning.
Right. It's from.
आणि फुल स्क्रीन करायचं पण सांगा ना त्यांना.
Yes, from beginning click केलं की होऊन जाईल मॅम.
Is it now?
Please click again from beginning.
किंवा स्लाइड शो नको का खालचं क्लिक करायला?
Yes, ma'am. होतं ते.
अच्छा.
I think it's done, right?
No, sir. Just click from beginning.
We are seeing
Done
your
it.
slides, but they are not full screen.
Okay.
नीचे आइकॉन है देखो 69% लिखा है उसके जस्ट पहले.
So I have done that.
That could be full screen, right, Parsha madam?
No.
नहीं?
Not yet.
दिख रहा है स्लाइड सर मगर फुल स्क्रीन नहीं है. हाँ वो 69 के जस्ट पहले वो स्लाइड शो का है वो क्लिक करो.
Yeah. Again, I have done it. Is it still not?
Sir, just click from beginning. Double click.
वो भी किया. Double click. See it now?
फुल स्क्रीन नहीं आ रहा है.
Still not. I'll stop share करके फिर से करता हूँ. Stop share करके फिर से करता हूँ.
ट्राई करो ना सर. हाँ.
Stop sharing. Share and
yes, it's coming. Yeah, full screen.
Okay. Now, good evening, everybody. My special regards to all the BSA office bearers. And I really thank this BSA for putting this topic for a discussion. Now, I have a few things to tell you about before I start about this. Number one, this is not a presentation and talk. This is about a discussion. This would have been great if we would have done it in a physical meeting. But it's okay about this to go ahead and inform about this palliative care thing on this platform also. What we discussed with Dr. Shilpa is that Shilpa madam wanted all our anesthesiologists to have something different than anesthesia. We all have a great capabilities from the understanding of the patient and understanding of the various aspects of patient management. We all apply this to the anesthesiology, but we have a lot more things which we can do apart from giving anesthesia in the operation theater. So, sorry, wait a minute. The slides are not moving now.
You can double click on this first slide. Double click कर दो first slide, and then अभी करो.
Okay. So I'll just introduce how this topic has come up in the mind. So Shilpa madam wanted to speak me about my experience. So here I am trying to share how the different things comes into the mind and how the different things are happening. First and foremost thing that we are working in a group, we are working in a team. We have a huge team which is managing the anesthesia department. Now, when we are working in a group, you have a little more free time because there are a lot of helping hands to work about it. So when you have a lot of free time, you try to explore new things. And of course, on the lighter note, I would say that we keep on thinking how to increase our financial independence or how to increase our income. On those grounds, when we start thinking, then we realize that we have a lot of free time which we can utilize in a different way. We all know there are different ways to increase our potential, increase our day-to-day income. I have just narrated a few things. One is the intensive care management. A lot of people say that the intensive care management is a very specific job. It has to be done by certain type of the people after certain training and all. But I have seen very, very good and very, very great management by all the anesthesiologists whenever they are posted in the intensive care. Of course, they need to have that kind of mindset to learn and apply to the patient. But anesthesiologists are excellent in managing the emergencies in the ICU, which everybody agrees. That is one area which in a group we are managing. We are managing a couple of ICUs and where our team has a designated people who manage intensive care. Pain management, as we all know that pain management, a lot of anesthesiologists does, a lot of anesthesiologists does in the free time, a lot of anesthesiologists done as a full-time practice also. I am also doing a pain management at very basic level. But whenever I used to do this pain management, I have one thing always in my mind, that pain management per se gives you a focus on managing only patient, where you miss out to the lot of other aspect of the patient management. And all the patients who are chronically pain are generally onco or a neurological disorders. And we need to look at the lot of other aspects of the pain management, which we don't apply unless and until we learn something specific things to manage this kind of chronic pain management. So pain management is another area where we can apply our knowledge. A lot of people says that pain management is a full-time job. It is not a part-time job. But believe me, I tell you, whatever we have learned in our anesthesia practice, it can be directly applied to the pain management, whether it is acute pain management or it is chronic pain management. We are the best people to to manage the opioid doses in a particular patient. So we are the best people to understand this. So let's not think that pain management is something very, very special and requires a full-time job. We can add to our portfolio that pain management can be done. Hospital designing, hospital administration. These are the two areas where a lot of anesthesiologists have ventured and they have successfully managed that. Medical legal advisory. Now, this is the area where we probably will play a very large role in the future. One specific reason for medical legal advisory is that anesthesiologists have a knowledge about all the systems in the body. And we have seen all the type of the surgeries, we have seen all the types of the patients. So in a given situation, if somebody comes to the anesthesiologist with a problem, anesthesiologist will be probably the best person to tell that what to write and what not to write. On the extent of that, in some situations where we require to produce data in the court, supportive data, supportive evidences, we would require an expert help for any kind of the lawyer. Now that again is an expert job. Say for example, there is a maternal mortality and you require a lot of data to produce in the court. Then the anesthesiologist would be the one person who has a knowledge of both the sides, obstetric side and anesthesia sides, and even a physician side. And then we can produce certain data from the journals to the rescue of a particular doctor. So medical advisory is going to be a big thing in next couple of years. Cashless related administration, I am not going much into detail, but cashless related things are increasing in the current situation. And how to write, what to write in a cashless. Right now, all the non-medicos are doing and a lot of things are happening at all the level, hospital level and cashless insurance company level also. But that the correct way of putting it into the cashless system is very, very important. And I am not talking on a theoretical grounds. My two anesthesiologist friends in the Gujarat are doing this job very, very efficiently. And they are into this in a very big way. So this is cashless related administration job is also going to be a big thing into the world. And the seventh most important is palliative care. Now, palliative care, why the palliative care? So I have chosen already intensive care pain management. We will probably go into the medical legal advisory in a couple of years, but the team is now geared up for the palliative care system also. Now, why we are the best of the palliative care, which I told you on a rough basis, that we have a fair idea about all type of the disease and their interventions and their outcomes. We have all the possible and needed context. Now, what happens with the palliative care patients? Being into the ICU work also and always into the onco theaters also, I have seen one thing. After a point of time, when the patient discharged from the ICU and when they are at home, there are a lot of things which are needed, which are not being informed to them or supported to them in a larger extent. Because hospitals are very busy, physicians are extremely busy, they do not have time to manage those things. And I have seen that many chronic diseases, say for example, neurological disorders, can be very well managed at the home if some palliative care physician takes care of this patient at home. So it is a role which is bigger than the MBBS doctor and maybe a slightly lesser than an MD, very, very busy MD physician. But this role can be very well taken over by the anesthesiologist, since we know all the systems of the patient, respiratory system, virological system, abdominal systems. We take care of pain management of that patient also. And if pain management, during our pain management, if there are certain side effects, then what level of intervention is required, that also we can do. We have all kind of friends in our fraternity who can help us in each and every problem if we get stuck in that situation. Our knowledge of opioids is the best. So, and even the most of the hospitals wants anesthesiologist signature for the opioid dispensing also. Now, opioids management, I have seen from the various consultant level. Say, for example, orthopedician managing the opioids, physician managing the opioids, and anesthesiologist managing the opioids. We have a fairly good idea about managing the opioids in a particular patient, be it is an oral drug, IV drug, or be it is a drug by giving an intrathecal route. Of course, we are very, very good with our blocks, which no other physician or no other orthopedic surgeon can do. So we are good in all our basic knowledge of anesthesiology, which can be directly applied to the palliative care patient. What we need to learn more. So it's not that anesthesia we have learned, so we can easily go into the palliative care. We have a certain problems in our learning, problems in the sense we are focused in anesthesiology. So we spend little less time interacting and communicating with the patient and the relatives. So we have very minimal time to communicate, that which we need to learn on the larger context if we want to do palliative care. Overall view, like a perioperative physician, is not yet very well established as a particular to the anesthesiologist. We go to the hospital, do quick PAC, we give anesthesia and shift the patient, and probably we may call that patient to 1 or 2 times and then forget about that patient. So that's called a very limited role as an anesthesiologist. But as a perioperative physician, we have a larger role, starting from optimization of the patient to the taking care that that patient should have a pain-free couple of days post-operatively. Now we have a lot of free time because we all are generally working in a morning hours and afternoon hours, and evenings are generally free, which can be utilized to implement our skills as an additional patient care. Now, I mean, when I have started thinking about the palliative care, how the thing has come into the mind. So it was about some close relatives who are being minimally attended by the physicians, and they keep calling you for the help. Now, once you see such kind of things happening in around you repeatedly, then you realize this is the area where people are still struggling to get the best of the help. General practitioner has got a limited knowledge. Physicians does not have much time. Physicians are interested to get the patient admitted and treat them as a hospital protocols. And this was the area where it was lacking a care. Then I started understanding that let us understand that what this kind of people needs. And in those days, again, COVID has come up. Now, COVID has again given an idea that home healthcare is so important. It is so important that a lot of things can be managed at home, but we are not able to manage at home because of the lack of the thought process. Forget about the infrastructure. There is no thought process that we should manage this kind of the patient at home. So by doing this kind of analysis, I have went again and again and reading about this. And then I realized what will be my benefits if I learn palliative care. So typically my palliative care reading, my palliative care understanding, my palliative care, meeting my palliative care friends will make me better communicator. So now the communication labs, which was anesthesiologist in a general has, which is less. I mean, you will have more communicative with the patient. We are working like in a whole perioperative physician. These are giving us a lot of self-satisfaction, which a lot of time I hear from a junior anesthesiologist that we are behind the curtains and we are not being seen by the patient and we are not given importance and we don't get that kind of satisfaction. So I would say that self-satisfaction of treating patient clinically and appreciation from the patient and relatives gives you also a lot of sense of wellness in the mind as an anesthesiologist. Improves own understanding of acute and chronic pain management. Here now I would stress about this. After learning palliative care, I have started focusing on more and more on the side effects of opioids, or side effect of the other drugs, or the side effect or discomfort of the patient when they do day-to-day activity. Say, for example, we give a block, and when after the block, certain people does not like that sensation of paresthesia. Some people are very, very annoyed about this. So then this kind of thing I have started understanding more. And this has improved my acute pain services also. Acute pain services we do, and then again we go home and then we forget. But after doing this palliative care, I realized that there are a lot of gaps in acute pain management also, which can be filled with this overall comprehensive knowledge of the palliative care. Of course, it is an additional source of income, which I always tell my all the juniors that you should have something which can give you an additional source of income, because you have a lot of time and skills and you have spent your 3 years in anesthesia. Why not to use that skills and earn something extra? I am in pain management since long, but was feeling partial involvement because my focus was give a block, give a pain relief, and forget about this patient. Give a block, give pain relief, forget about this patient. Then after learning this palliative care, that overall understanding of the patient is improved. When we do something new, we need to learn from the recognized authorities, and we need to be in that particular group. Say, for example, we want to go for a trekking and learn trekking or a marathon or something like that. We need to be in that particular group. We'll keep talking about it, keep experiencing, start doing at the basic level and then advance. Similarly, in a palliative care, we need to start from the basic. We understand that we talk about this with the palliative care physicians, pain management consultants, overall general physicians, what they need. And then my first step was that British Medical Journal, which they are offering, which is a very basic, understanding. I would say that palliative care and home health care has increased after the COVID pandemic. So we got a lot of time and to read about it. Now, reading a palliative care is a wide subject. So it's like, again, you are preparing for some MD exam and talking about and understanding each and every aspect, especially neuro and oncology. Oncology and neuro is in a very extensively written about the palliative care, and we need to understand outcome of the patient so we can decide whether this patient is for the palliative care or we can do something aggressive, not only palliative care, and we can do some curative and we can give a lot of good life to them. So overall, palliative care is an extension of a chronic pain management in a larger perspective. And that larger perspective is very well in our capacity to understand, because we have learned everything in our anesthesia days. Only thing is what was lacking is a thinking on that and applying that particular thing on a particular patient. Now, what I would see as a future for palliative care is that every hospital will need a separate palliative care unit in the future. And many courses are now available to learn, which are after MBBS, the short courses, and then a lot of training like a Tata Institute or a Cipla Institute in the Pune. And everywhere there are people who are getting trained into the palliative care management system. So this work is going to be increased. What I felt about this is the best part. After this learning, we can manage our close relatives and friends much better than just a hospital. So when I get that kind of confidence and I manage them at personal level, that gives us a lot of satisfaction. So palliative care is one of the great way for us to promote our anesthesiology branch. This talk Dr. Shilpa has kept today for this kind of forum is to motivate more and more anesthesiologists to do something extra than what we are doing in anesthesia in the OT. We want to change our perspective as an anesthesiologist in the society. For that, we need to do something extra, which we are doing since so many years. So intensive care, pain management, palliative care management, medical legal advisory, hospital administration, all these options can be very well applied, and that can increase our presence in the society. So we are very well recognized, much better recognized than what we are right now. I would say that the palliative care is a great way to go ahead, and we must think about this. Thank you very much. Thank you, Shilpa, for the opportunity.
Arey, sir, thank you. Thank you for taking out time today. Yeah, over to Priyamvada, madam.
Yes. Thank you so much, Kalpesh, sir, for giving us an insight into palliation. As you said, sir, analgesia is a major role in palliation, and who better than an anesthetist to take care of that? I have worked myself in two years in Tata Hospital, and the way the anesthetists work there in palliation and chronic pain is really inspiring. Thank you, sir, once again.
Thank you. Thank you, everyone.
Sir, one question, if Shilpa ma'am allows.
Yeah, please. Should we take the questions?
Yeah. Shilpa ma'am has put one question, which even I want to ask. Sir, palliative care, is it a visit, home visit, or is it an OPD basis where we can do the consultation?
If you have a patient who cannot be brought to the hospital, you need to do the home visit also. So in our team, we have, in my team, there are physicians who are in our team, those who are posted into the ICU. They go and visit the patient in the home and assess the exact situation. Say, for example, last week only, one CA ovary patient having an extensive MATS and having a severe back spasm. She was not able to get up from the bed, and relative was a doctor, and he requested that please come and see this patient. So this situation comes up in a chronic pain management also, that you do require to go to the hospital home visit also. But I have my OPD, and we try and mobilize patient to the clinics as far as possible.
Okay, thank you, sir.
Dr. Priya, are we going to take Neelam madam's questions, or should we go to Charu madam?
Ma'am, as time permits, you suggest, because I have noted 2-3 questions.
I think we'll finish off. Then we can hand over to Krupa madam.
Okay.
Yeah.
Neelam ma'am, can I?
Yes, please.
Okay, ma'am. One of the questions is Clonion spinally approved by FDA?
No, Clonion is not approved by FDA, but there are many studies, and if there is something wrong goes in your patient, you can always give the reference of these studies where Clonion is extensively researched and studied in these groups. But it is not FDA approved drug.
Yes,
only opioid is FDA approved.
Okay. Yes, ma'am. Thank you, ma'am. And one more question. Is there any limit to how many drugs can be used in multimodal analgesia in one patient?
Good question. Who is asking this question? So this question is, this suggests the difference between multimodal and polypharmacy. What is multimodal analgesia? What is polypharmacy? Please note, if you are using too many drugs, you are doing something wrong. You are using the drugs from the same group, so they are not acting. The idea is to use drugs from different group, or use the sites where they will act at different sites. So you will not need more than 2 drugs. If you are needing more than 2 drugs, then you are doing something wrong. Please go back, check your drugs, they are from which group, or check the mode of action of these drugs.
Yes, ma'am. Very important point to be noted.
Yeah, thank you. That was my question. Yeah.
Can we take one more?
No.
Can we take one more question?
Yeah, yes.
Please go ahead.
Ma'am, there was a question that for breakthrough pains, are the patches, like for example, buprenorphine patches, effective?
When they will apply that patch? Because patch itself takes some time to act now. So
yes,
how can a patch act in breakthrough pain? We have to give something instant. So tramadol will be a better option. Nalfi will be a better option if you are already not using opioids. If you are using opioids, block, if possible, will be a better option. See, because in fentanyl patch also, I regularly use in very major surgeries where there is 4 or 5 hours between the induction and extubation of the patient shifting to ICU. Then also make sure that you are mentioning your fentanyl patch properly in your notes. Also, you are labeling your fentanyl patch, you are giving it in the over, so opioids are not repeated and you are not giving overdose of opioids, right?
One more question I would like to address. It is somebody has asked that you give epidural in colorectal surgeries pre-operatively, something like that. In that case, what happens is usually a neckline is passed in colorectal surgeries because these patients are going to be on IV fluids for a longer time. They are not going to have any oral feed. So you check your CVP, how much is it? And usually, as rightly mentioned by that member, the patients are usually having too much laxative and bowel preparation. Check your CVP and accordingly you decide. If you want, you can give ropine in epidural and then go ahead with the surgery.
Yes, ma'am. Thank you so much, ma'am.
Yes. So I think the questions are over. Somebody is asking pre-op local infiltration. Surgeons don't like. Yeah. Surgeons will never like it. But you just read the pain pathway in front of him, so he will stop it and he will say, okay, you do whatever you want. See, knowledge is the power ultimately. How you explain them now, then they will agree to the thing. Thank you so much. I think the questions are over now.
Krupa madam, are you there?
Yes, ma'am. Good evening, everyone. Thank you, Shilpa madam. I would like to introduce Dr. Charushila madam. Madam is working as a freelancing anesthetist in Borivali area since past 25 years. And madam has been in marathon and triathlon since last 6 years. So let us hear from her about her journey towards the Ironman 70.3. Over to Charushila madam. Welcome, madam.
जायचंय मधुरावर जायचंय. Can you see the screen? Hello?
Yeah,
Hello?
we can see your screen. Yeah, madam, we can see your screen. Can you just make it full screen?
Good evening, everybody. Thank you so much for inviting me here. This is the second time I'm going to speak in front of the audience, so please bear with me. Maybe I will stumble, fumble. Please bear with me.
Can we also see our Iron Man?
Yes.
We want to see the Iron Lady also.
Iron Lady, okay, yeah.
Can you see me now? Hello? Am I visible? Hello?
Yes, hi, madam. Yeah. Volume thoda vadva.
Is it okay now?
Still little low. If you can try.
Is it better?
Yeah, this is better.
Yes. Excellent. You can adjust your screen also, Charu madam.
Yeah, you can move ahead by double clicking the first slide.
So as Arthur Ashe said, success is a journey and not a destination. Doing is often more important than the outcome. So I would like to share my journey with you. I hope you like it and be inspired by it and take on the challenges and push the boundaries. I was always an active child and interested in outdoor activities. I learned to swim at the age of 5. School and college brought the opportunity to indulge in various sports like badminton, basketball, and track events like 100 meter sprint. But medical college, followed by internship, PG, and marriage, curtailed my time I could invest in fitness. A year after my son was born, I resumed getting into about 1 to 1.5 hours walk. Here, I would like to mention the track where I used to walk. I used to very often meet Dr. Kamdar sir and madam sometimes. And he would always say, Charu, kitti go chaltes tu, kitti chaltes ka tu. And I would just laugh it out. I said, sir, thoda sa fitness साठी करायला लागतं आणि मला वेळ पण खूप आहे, तर सुरू केली practice. So it was just the beginning of my freelancing in anesthesia practice as a consultant. I had some time to spare for the workouts at the gym. But my enthusiasm was short-lived. As I came down with a knee injury, there was a rent in PCL while playing badminton. The fact that surgery was not an option compounded my forced break from my fitness training for almost 2 years. The result was that despite my healthy, conscious eating habits, I gained 10 kgs. I wasn't happy with the image that looked back at me from the mirror. So that was about 2 years. This is me after 2 years. And after 2 years, I got a go ahead from my ortho, Dr. Sanjay Garude, to resume my training. In 2006, women of all ages and to do a half marathon. Make fitness a habit. Motivation is what gets you started. Habit is what keeps you going on. That's how I went further with my training. They say the universe conspires to fulfill your dreams, and this happened with a friend introducing me to a running group called Road Burners at Borivali National Park. Now, Ashe quotes about success and achieving success. Important key to success is self-confidence. Important key to self-confidence is preparation. I went through structured training for endurance and strength, which brought me to the start line of a 10K race within 3 months, and that was my 50th birthday. So this was the first step of reaching my goal of completing a half marathon. I trained hard and consistently, and finally managed to cross the half marathon. My first half marathon in November 2016. That was the Vasai Virar Mayor's Marathon. The running bug bit me, and I did almost 15 half marathons in 2 years, which included the first marathon. The marathon was Standard Chartered Movement Marathon and the Endurathon. Now, there's a special mention I would like to here to make about the Endurathon, which is held at Borivali National Park every year in the month of July when it pours like mad. So this covers a distance of 25 kilometers, and there are two hills to be climbed twice. One is Gandhi Tekri and one is Canary Hills. So this is the most beautiful place in Mumbai. You all must visit it, especially during monsoon. It rains through the day on that day, and it is so enjoyable. It is so beautiful. It is lush green. This is the national park, and this is my running group, the girls at Canary Caves. At this stage, the recreational sport in India had expanded to include triathlons, which required the athlete to swim, bike, and run consecutively at the same event. With my swimming background and my vacation cycling in school, I decided that I could give such an event a shot. My dear friend Shilpa, she's in Cambridge, UK, she registered me for a sprint triathlon. The distance was just minimal, 350 meters of swimming, 20 kilometers of cycling, and 5 kilometers of run. I cruised through this race without any preparation. So further going ahead, I thought, why not give it a shot for the Olympic triathlons, where the distance is 1.5 kilometers of swim, followed by 40 kilometers of cycling and 10 kilometers of run. I did a couple of Olympic triathlons. I did a couple of Olympic triathlons at Jaipur, at Kolhapur, at Aurangabad, and I got some prizes here. So to go ahead, enter Ironman, who announced the first event in India, Goa, with its access to the sea, good roads, and athlete-friendly environment. It became the ideal location and venue. For the Ironman, it includes The distance included is 1.9K swim, cycling 90K, and run 21 kilometers. So it was beyond my endurance capacity. I asked my coach, Daniel Vance, whether I stood a chance at attempting this event. He replied that as long as I could invest the time and be consistent in training, I had a good chance of completing it. Then followed the grueling hours of long laps in the pool, open water sea swims at Kudal and Gateway of India, long exhausting 60 kilometers bike ride. So this is, I would like to mention here, this is my bike trainer on which I mount the bike. The rear wheel is removed or detached, and then I mount the bike on this. And then I can do indoor training because during monsoon, it's not possible to take out your cycle. Just a minute. And that's my bike, which I bought after my sprint triathlon. That's a road bike. There were long, grueling hours, about 10 to 12 hours a week of training. My day would start at 5:30. It would start with strength and conditioning of about half an hour to 45 minutes, followed by a 1 hour run. And during the day, in between the surgeries, when I would get the time, I would go for my swim workout, which would again go on for about an hour and a half, or maybe a bike ride of 1.5 hours. In all this training period, I have to take care of my nutrition as well and the hydration. Otherwise, there are chances of overtraining, which is a setback, also getting injured. I could manage that fairly well. This whole training, it really burnt me down. I needed a break. Just 1 month before the event, I took a short break of 4 days and I went with my friends to Goa. Now, at the airport, a friend of mine, she said, Charu, you have got that lovely copper glaze. Every girl would like to flaunt. I said, yes, I've earned it, rather burnt it. With all that training, I reached Goa for the event. It was in October 3rd week. So, 3rd week of October in Goa, it just rained and poured just 3 days before the event. And I went for the bib collection. Bib is the number what you get for the race. So I went for the bib collection. It was in ankle deep water. Deep down, I thought in my mind that there is some problem somewhere. I said, but now that I've come here, let me go ahead. So on the race day, I was at the sea. I was at the beach at 6 a.m. with 1,000 triathletes. On a wing and a prayer, I dove into the sea, uncertain how it would all pan out. I was required to cover the swim distance, which was 1.9 kilometers in 1 hour and 10 minutes. Now, it had rained 3 days, just 3 days prior to the event. What happened was there was a current in the sea. So there was a drift. We would drift away from the course of this swim course. So what happened was the distance covered, instead of 1.9 kilometers, it became 2.5 kilometers. I covered that in 47, that was okay. After I came out of the sea, I had to again run for 300 meters with those heavy legs. I rode the bike and the distance was 90 kilometers. So there were 3 loops of 30 kilometers. Every loop, there was a climb, quite a climb, and I was sapped and drained and completely burnt out. By the time I came back to the transition zone, I was very dehydrated. I had 21 kilometers of run ahead. It was in 3 loops again, 7 kilometers. Again, there were climb. Every loop, there was a climb. Fatigue had set in and my calves felt like there was lead in my veins. This is where the mental training, mental endurance helped me. As you train physical, what happens is gradually you get strengthened, you are mentally strong, and you can do more and more distances. So this what happened is I carried on with my running. It was going to be close because I saw growing concern on my coach's face and my friends' faces. When I came into the final 400 meters, I could hear my coach cheering out loudly. As I edged closer, he shouted, "You've got just 8 minutes before the final bell rings." I dug deep with panic gripping me and found a reserve I did not know existed as I sprinted towards the finish line and crossed in 8 hours and 24 minutes. I had done it with 6 minutes to spare after all. Elation and exhaustion brought me to my knees in the sand as I relished my achievement. These are the pictures. This is it. This is, I have since, during the lockdown, I did a diploma in clinical nutrition and dietetics and a couple of certification courses, a foundation course in nutrition, sports nutrition, weight management, and a marathon trainer's course. I'm going to use this training and the educational background, and I'm going to start a fitness training group on the 2nd of April with a runner friend of mine and my coach as a mentor. The group, I am going to call it as A Mile More. The last thing I would like to say here is you can always start late whenever you can start. Stay consistent. Stay away from injuries and make it a habit. The one more thing I would like to say is your fitness journey is not always about you. Inspiring others along the way is just as important. I hope I inspire at least one from this group. Thank you so much.
Charushila madam, hats off to you. Such a thrilling journey, oh God. Yeah, over to you, Krupa madam.
Thank you, madam. Charushila madam, it was such an inspiring journey. All your life experiences and your self journey with your all successful quotes, and especially talking about mental strength after the physical strength was so inspiring. I hope everyone should learn this lesson about the fitness and start training themselves in one or the other way. Thank you, ma'am. Shilpa ma'am, can I go ahead with all? Again, vote of thanks.
Yeah, please, Krupa madam. Yeah.
We are at the end of the session. At the end of the session, I would like to thanks to all the Maharashtra State Chapter ISA office bearer. Sorry, Kamdar sir wants to talk.
I thought you must.
No.
HMIS पे वर्क करना है चाहिए बहुत ऑटोमेशन का जरूरत है.
Yes, you want the point. No, give all the points, no? Operation and HRMS.
Varsha madam.
It's Friday, ma'am. अब कल तक दे दो या परसों तक दे दो because I'm going to
pressure cooker only है ना.
Varsha madam, can you mute everyone, please? Are you there, Varsha madam?
I did all my investigation.
Yes, ma'am. Yes.
Yeah, please. Yeah, Krupa madam, please continue. Saleh sir is
okay.
Wants to be,
yeah. Thank you. Thank you all the Maharashtra Chapter ISF office bearers to take out their precious time to address us. Thanks to Manisha madam. Thank you, Dr. Avinash Bhosle sir, for talking to us and giving us insight about the fitness in spite of traveling and going for a case. Thank you, Saleh sir, for giving an insight about the safety goals, giving all the appropriate and good examples of all the cases, and also all the features for practicing very safe anesthesia in the era where we are always bound by some or other medical legal cases. Thank you, Neelam madam, for her in-depth knowledge about your pain and its multimodal management, and also giving examples what to do in various types of general surgeries. Thank you, Kalpesh sir, for giving and increasing our horizons for about different scopes of anesthesia. And also about his specialty, now his new specialty, palliative care. Lastly, thank you, Charushila madam, for her journey to inspire us. Lastly, I would like to thank you, Kamdar sir, Yogen Bhatt sir, and Shilpa Madam for giving me this opportunity to speak in front of you people. Thank you all delegates for attending this wonderful session by all. Over to you, Shilpa Madam. Madam, you are on mute. Shilpa Madam, you are on mute.
Thank you, Borivali ISA team. Thank you, Shilpa, so much.
Thank you, Saleh sir. Your lecture was really great, really great. Thank you so much. Thank you, sir.
Yeah.
Yeah, thank you, everybody. Bye, everybody. Have a good dinner, good evening, fit. And Charushila madam must have already gone for running. Kamdar sir, काय तुम्हाला म्हणायचंय का?
Thank you, everyone.
We are not going to have dinner after Charu's talk.
I just wanted to salute Charu.
Yes, sir.
Yes.
I have no words of appreciation, but I just feel like saluting her.
My God, sir, thank you so much.
And second thing, I wanted to talk to Kalpesh about more about the different things that he is managing. One of the things that he can add into that is management of the ambulance, giving ambulance services to the patients. And I just wanted to suggest to Kalpesh, that's all. Thank you.
Yeah, I agree. The cardiac ambulance services are delayed and they're not fully equipped.
Yes. And anesthetist is one of the best person to be there in the cardiac ambulance.
Yes. Kalpesh sir, are you there? Kamdar sir, can we end the meeting? Neelam
Yes.
madam?
Please, please. Yeah. Very nice.
Thank you, everybody.
Please. Thank you, Shilpa madam.
Thank you, everybody. Yeah, thank you, madam.
Yeah.
Yeah, hopefully we'll have a physical meeting soon.
Yes.
In 2 days.
I think next meeting we should have physical only. Now this is too much of virtual.
Yes.
I think this should be the last virtual meet. Chalo, bye everyone.
Thank you, everybody. I'm ending the meet.
Yes.
Thank you, Varsha madam. Thank you, Abhijit sir.
Yes, thank you, ma'am. Yes.
Yeah.
Bye, ma'am.
Yeah, bye. Thank you all, moderators. Thank you. Bye.
Thank you, ma'am, for giving us opportunity. Thank you.
Arey, no, Krupa madam, you are best. Thank you so much.
Thank you.
And Priya madam and Ashwini madam. Yes.
Yes, ma'am. Karu end meet.
Okay.